my wife's family is Polish, and so she makes a few things that come out of her tradition that she likes, but one of them that the family likes is something that she calls prisoner's food, but it's not really. That's, as a child, that's what she called it. But it's just dumplings and rice and milk, and it's boiled and cooked up like that with some salt, and it's very tasty, and everybody sits around and eats all of it they can get their hands on. I started about 1975 in the HMO business, and I was a director of a federally qualified HMO in Houston, and so my job was to find medical services for people that were enrolled in HMOs and to arrange contracts with physicians for them. And I did that for about 5 years as an HMO, and then I started doing contracting with hospitals and physicians across the United States for PPO programs. Mm-hmm. And it was always, can I find physicians and hospitals that will pay attention to patients, take care of them, do it economically, and report what they're doing? And so as a consequence of that, we built a fairly large organization of physicians and hospitals. And I continued that until about 1995. And in 95, I decided that I would sell all those things that I owned to somebody else, and that I would try to do something to help people who were not insured and who were not getting healthcare benefits. As long as you're doing something to help people make money that don't need to make money, and those to save money that probably don't need to save money, that your life is kind of pointless, all right? Because if the population that needs help, which is approximately half of this population in the United States, at least it is where we are in Texas, it's about half the population is not able to do things either financially or for themselves or as a community, then somebody's got to do something about it. So I decided to quit the business side of what we were doing, and I did. And I went to do volunteer work at the Catholic Worker Organization and discovered there that they were hospitality houses, and they were, taking care of people that were in transit mostly, at least here, that's what was going on, but were doing good work and were understandably trying to involve community in doing it. But what they were missing, of course, was real community planted in one place and spreading out. And so my connections with physicians and hospitals led me to think that I could do this for people in the medical area, because that's the relationships that I had. And so I could always arrange for medical care or some help for people that were in need of it. And that it ought to be a local issue and not an issue for the travelers. All right, which is what the hospitality houses were about, people in some kind of transition. So I wanted to try to do it for people that were within a community and to try to rebuild community. So I started doing things like that. And in the middle of doing all that, a group of physicians that had been associated with me and had been running an association of physicians contracting with insurance companies found that they were deprived of their contract because the company that was doing it, in this case it was Family Practice Association of America, and it was out of Florida and California and had evolved into Texas and contracted with most of the insurance companies and most of the physicians to be the intermediary for them for getting prices and care delivered. But they had gone broke, and they had attempted to take the money they were getting from the insurance companies and not pay the doctors with it, but to try to rebuild another system underneath it, and they failed in doing that. So our physicians that were part of that program came to me and said, Don, we have 1 month to reorganize into a new association and to offer our contracts to the insurance companies, or they're going to cancel and move our patients to other doctors. And that was about 80 physicians that were in the southeast part of Houston. And so I said, I'll probably fail at doing that because 30 days is a real short period of time to get that done. And while I've had a lot of experience, I'm not a genius, and I can't just make big insurance companies do things they don't want to do. And if they want to move them to other physicians, they will. But if you want to try, you give me a 30-day agreement, and I'll try to do that. But you have to fund it every 30 days until we decide to quit. So that was in 1995. And we succeeded. In 30 days, we reorganized, and an attorney and I did it. And we said, look, let's not make this too complicated. I'm going to go to the insurance companies and say, you can pay me a global capitation and we'll take care of these things with these people. You have been paying them in the past that way, and they will accept it in the future. And they're just under a new organization now. So I went door to door to all the insurance companies without appointments and a little briefcase in my hand and a card saying, I am begging you, don't throw away all these patients and doctors. And they did it. And we had a contract, and we performed on it. And we were the only, for the first, well, my deal with the doctors at that point was that, look, I have quit this as a for-profit enterprise. I'm a nonprofit 501c3 organization of laymen that believe in doing the corporal works of mercy. So if you will give the contract to that organization, we will charge you exactly the same amount of money that some big business would have charged you to run your business for you. But we will use that money to rehabilitate the poor. And maybe the poor are the people that you're taking care of. So you can refer them to us. So we did it. And oddly enough, the doctors made a lot of money. And they've made a lot of money every year since 1995 in this program. And the program has grown from what was 80 physicians then to about 500 now throughout the city. And we have served not only the commercial population, but we served the Medicare population. And this last year, we were #1 in the United States in savings for Medicare on the ACO program, because it was an easy walk for us to go from what we were doing to doing an ACO program under the Obamacare. Now, we've been called various things in the past as physician organizations, and I'm speaking as a representative of them as opposed to for myself. But they say that it's an HMO was what it was in the 1970s, right? And in the 1980s, it was a PPO organization, and now it's being called an accountable care organization. And I suppose that they just wanted to emphasize the fact that these physicians were going to report what they were doing and to automate what they were doing and to take care of patients, and if they did a good job, that they would be paid a portion of the money that was saved, about half of it. So that's what kind of organization it is. Well, the first one that we did it was called Physicians ACO, and it saved on 6,200 Medicare patients, it saved $10 million the first year, which was #1 in the United States. So we stand in that shadow of doing that kind of work, but still we're doing the same thing that I quit doing in 1995, because we're still saving money for people that don't need to save money. So Medicare population has universal health insurance. They have benefits. They have everything, right? And we're saving money for them. And the doctors who are getting paid are doing well. They're profiting from their practices, so we're making money for them more than they're making right now. So I'm still in that same trap that, by golly, I'm still saving money for people who don't need to save money and making money for people who don't need to make any. And then I'm having to beg them to redistribute it in some way or to improve things in some way. So I'm back to saying, at that point, I said, well, let's find out what we can actually do to take care of people who are outside of universal health care and who are outside of any kind of system of access. So we opened a free clinic just to discover what the problem was, because you don't know what things are until you ask. And you don't know the truth of something until you ask the people who are living it. You know, in this case, patients. If you want to know how to fix a system, ask the patient what's wrong with it. You don't ask the guys at Harvard and the ones at Berkeley. You ask the people who are getting health care, what's wrong? So we went to a clinic that the doctors volunteered to man, and one nurse in particular, one nurse practitioner called Lee Atama, who was also a minister, a Presbyterian minister, and he said, I'll just do it. Just send him over and I'll do it. And so everybody that came to that clinic, we asked them a number of questions. You know, did you like the service? Did it work? Is it going to help you? And if you could pay something for it, how much would you pay? And they said, well, you know, we could pay $20 a month, or we could pay $30 a month. But that was about the range, $20 to $30. So after it was over, 4,000 interviews later, all right, we added it all up, and there was a general consensus. The majority of the people could pay something without asking them whether they made money, why they were at the free clinic to begin with, and whatever. So at that point, we said, what does that mean? What does $30 a month mean for a clinic if every patient paid them $30? Well, how many people can a clinic take care of? How many people can one doctor take care of? The answer is that reasonably they could take care of about 1,000 people if they gave everybody time and were careful and saw them over and over again. They could take care of about 1,000 people. All right, and most of them take care of twice that many, all right, but they do it by getting a few more hands. They get some help when they do that many. So the average capacity is about 1,500 lives. So if you paid me $30 and there were 1,500 of you, how much money would that be? You know, so it's like what, $45,000 a month? Wow. Well, what's 45 times 10? That's 450,000. And then you add another 90. So now we're over $550,000 a year just from the poor people who don't have anything volunteering to pay you $30. All right? That's enough money to pay for the doctor, the nurses, the building, the taxes, the medicines, and all the other kind of things you can think of. And it is more money than doctors have made in Houston on the average from all of the waste systems that they use. They use 50 different insurance companies and Medicare and everything, and they average $474,000 gross. So it's less money. So if they got their money from the poor who didn't have insurance and were just struggling, they would make more money. So we said, this is quite a revelation. It's an economic revelation, it's a revelation to the people, and it uncomplicates things. Because if I'm paying my physician directly, then whatever my name is between he and I. Whatever I do is between us. And what records I want to generate are between us. So patient confidentiality and all that kind of stuff is out the window because it's nobody's business. And they can't get to it because there's no third-party rights involved in this. There's nobody trusteeing my money someplace or not trusteeing it, whichever way you want to look at that. So we said, well, let's do a cooperative then. Let's find physicians who are willing to do this and then ask patients if you want to prepay your physician. And then we had to think, well, you know, it doesn't end there because sometimes, you know, patients have problems that they didn't expect that require more than the services of just that physician they're paying $30 to. So we said, well, what can we do about that? I said, well, why don't we add some more essential services and go to some of those kind of providers and ask them if they will take some payment, some monthly payment for what they're doing. So we found imaging companies that would do that. We found a laboratory that would do that. I said, well, that then picks up a lot of the services that they otherwise wouldn't have. So we added that to the program. Well, imaging was about $20, and lab is a couple of dollars, so $22 more. Okay, now you have to pay for the club. I mean, we have to do patient advocacy. I've got to have, you know, somebody like Crystal to do something, so you have to pay them. And then you have to pay for other kinds of benefits that you didn't necessarily think you needed, but that people ask you about all the time and are paying a high price for. I mean, we found that there were discount dental programs, pharmacy programs, vision programs, towing programs, all that kind of stuff, all bundled up in packages, and people were selling them on TV for $40 or $50 a month. Well, most of that charge, the $40 or $50 a month, is just marketing and sales. It's not about benefits. It's not about anything essential. So we skinnied it down to what does that really cost? What do those services really sell for? And we found a wholesaler who distributes that benefit, and we buy that for $7. So we bundle that in, and the reason for doing it was that if our members are not hounded by somebody outside trying to sell them what looks like a benefit plan but is not really one, there's not really a substantial benefit involved in all that, at least that's canceled. We don't have to worry about their $40 or $50 a month going to something that is not benefiting them. So they can have everything, and then we can't be competed with in that regard. So then we said, well, what happens when people go to the hospital now and have to have surgery or something? What are we going to do? So, well, why don't we go to an insurance company and see if we can find an insurance company that will issue a group insurance policy to us as an association so that we don't have the pre-existing conditions and we don't have limitations and we can get comprehensive services, and then price it so that it's affordable and less expensive than the ones that they're buying from Blue Cross or Aetna or United or any of the big companies. So we found such a company. And they issued us a group policy. It has no underwriting. You join the association, you can have the group policy or not. No underwriting. And they're in 48 states. So it's just a matter of getting it approved in each one of the states as people have demand in those cities or in those in that other parts of the country. So that's what's happened.
But I was a caretaker for my mother. She was a nurse. But I live with my sister and her husband. And everybody in my family has health insurance because they have jobs. I'm an acting teacher. So I work on a contract basis, so I don't have employee insurance. And everybody in my family was so worried about me, and me too. So I had a doctor I had gone to about 4 or 5 years ago, and then one day I heard from someone in his office, and they were saying, we have this new program called PPC, and explained it to me, and would you like to come and hear about it? And so first of all, I was amazed that somebody called me about it. I didn't even inquire, and I said, yes, I'd love to, and so I came in and met a couple of people, and they were just great. So, you know, they told me I got imaging free for $75 a month. I got doctor's office visits free. And that's huge for me because, you know, so many times I'd be sick and I wouldn't go to the doctor. So I'd get sicker, and then I'd have to go to, you know, one of the emergency care centers. And so it was stressful. I mean, it was very stressful living that way. And I didn't imagine I would need any more imaging because I've always been so healthy. It just so happens I did right after I took it, but that's what really drew me was, you know, CAT scans and MRIs and mammograms. To be able to get those for free was just like a miracle for me. I actually even switched physicians, and I have a physician now. He knows me. He knows my history, and his office is great. They always call me Miss Nicki, and they see me anytime. It's just amazing. And I actually had, last year, I had kidney stones for the first time. I've never had them before, never had any problem. Suddenly I got kidney stones, and so I went to the doctor and found out what it was, and then he sent me to get a CAT scan, and within that week, he said, go see a specialist. I was trying to make an appointment with a specialist, but what happened was the kidney stone lodged right outside my kidney, created septic poisoning for me, really, like immediately, within a couple days after I'd seen him. And I was trying to get to him, and I passed out in my car at a gas station, and I don't know what happened, but somebody called 911, and I ended up in the emergency room in intensive care. Because I'd been using the imaging, I wouldn't have even known I had a kidney stone. If I hadn't gotten that imaging, I would have because I almost died anyway. So if I hadn't gotten that imaging and told me it was a kidney stone, I probably would have waited, because I wouldn't have gone to see a doctor, or I would have ended up in the emergency room, so it could have been much worse. That's what was so scary for me, because I do have this imaging, but there I am in the emergency room, so it didn't actually work for that. It's a very good policy, but I didn't take it at the time because I couldn't afford it. Yeah, and so right now I'm looking at it because I still don't have catastrophic insurance, and it's something I need to get. There's a woman who I speak to, she's like a representative named Crystal. She's been really available anytime I wanted her. She's been like a friend. It's like small town, private practice doctor who's treated you through your childhood almost. I mean, it really is like that, yeah.
I do basically direct work with the patient and the physician. So I'm enrolling patients, speaking with them about their needs. What is it that they need immediate assistance with? If it's setting up an appointment, getting some imaging done, or getting into a hospital, making sure that they have the correct benefit that fits their need and their budget. If there's anything that we can do for them, right down to some roadside assistance with what they've got, then we're there as well. We have a plan that includes legal help, roadside assistance, and also even some shopping. So we have other little benefits outside of the health that comes along with it, dental, vision, and although it's a discount, it's been great for a lot of people. We figured you never know, someone might be out there and trying to get to a hospital and may have some car issues. That could very well be a problem. And so we wanted to make sure that we could cover that as well, that we had more of a coverage, that we were different, that we didn't just stop at the health, that we had something else to go along with it. That plan right now a month is $84. It covers your primary care at zero copay. It covers your imaging also at a zero copay, lab, same thing, zero copay, and there's no deductible for this. And then you have dental discounts, vision, there's roadside assistance, legal service, and you also get the patient advocacy part of it with all of your plans. And so what that is just someone a person who's there for you to get you through paperwork, through phone calls, bills, just to help you out along the way. There's about 70 primary care physicians, and so I'm pretty much talking to different offices all week long. It just depends which physician the patient has or which they choose. And so the good thing is that they know who we are, and it's almost a family. It's a bond. So they know who to call for what, and it's very easy. It's very comforting to know that someone knows who you are and that they know what you're doing and they're as willing to help out and they're passionate about it as you are. Well, at that point, what we would do is help her out with the medical bills, get in there and take over that part and make sure that she has a guide, that we can guide her on what to do. Getting it reduced and getting a favorable or a more affordable rate. A hospital can charge you their rack rates, pretty much whatever they want to charge you for that rate, the highest that they can go up to. So we want to get it down to Medicare rates. I mean, Medicare is only going to pay them a certain amount, so why can't she? I mean, I think it's only fair. And that's what we want, fair and affordable.
And now we're involved in expanding our ACO program because we had access in that by creating an association called the National Association of Physician ACOs, of which I'm the president, and we formed a consortium to negotiate these kind of benefit programs for all the physician groups and all of these other ACOs around the country. So that now right now we have 20 organizations like this going from Massachusetts to Oregon and across the Midwest and the South. and we will probably have 100 of these organizations before the end of this year. Yeah, because you see, that's where it starts. If you get physicians who are agreeable to take the price and to take this, and to do the services, then you can add the cooperative. So you can enroll the patients. It's just a logical step. Now, there's some arguments because sometimes physicians get fixed in their head that they should be paid fee for service every time he shows up because they love being piece workers and they love, you know, the slavery kind of wage slavery thing because they get a higher rate than the usual wage slave. But they're really a wage slave, and that's what's going on. So we have to convince them that sometimes it's okay to get paid like that, but it's really better to get paid, you know, monthly in advance for what you do. And that way the accounting's better, and it can be the same amount of money. And I try to change their point of view. Say, quit looking at the fee for what you're getting and look at how much revenue you're collecting. And if you collect more revenue one way than the other, well, then choose the one that pays you the most revenue, particularly if it's good for the people that are buying as well. So that's the argument. So I have to go sell people on changing their mentality about how they're looking at the money. And it's not a cooperative in the way the government has defined that, because the government in the Accountable Care Act calls something a co-op, but by that, those are just the initials for what stands for community operated health plan, or it's really a mutual insurance company and has to be licensed as a mutual insurance company by the state. And so they're about reimbursement and insurance and not about cooperation between patients and physicians and helping one another. That's not what that's about. It's just another form of health insurance through a consumer-oriented health insurance plan is what that is. This is about a cooperative in the traditional sense, in the way that agricultural cooperatives have worked, or all kinds of buying cooperatives have worked. And this is a buying cooperative, and it gets humanized by the people that are working for it and within it.
One thing I make, and I know a lot of people make good marinara sauce, but I had a friend in high school whose mother was from New Orleans, and she made this marinara sauce that was so wonderful, and she'd cook pork chops in it, and that was really good because the pork would just come apart, and she would put cheese in the sauce because it would be so thick and wonderful. So I do that now, and it's great, and I just make it from scratch, and just has a different taste, you know.
I love Cuban food, I really do. So there's this dish called ropa vieja, and what that is just shredded beef. It's actually baked in the oven for about 4 hours, roasted, slow roasted, and it's got, you know, garlic, onions, cumin, oregano, bay leaves, and a little, you know, white wine, red wine, and it's delicious. I love it.
I love steak. My family comes from a family of ranchers, and I feel that veganism and vegetarianism would be disrespectful to my ancestors, who really clawed their way to the top of the food chain, and it's my job to stay there and honor them in that way. What I do for the patient-physician cooperative is I play Moneyball with doctors, and you know, we freed up a data set from the federal government about the way doctors work together, and I remember calling my partner Ashish when I first got the data, and I was like, this is wonderful, it's amazing, what do I do with this? And so we played around with it for a couple months, and then we brought what we had made to Don and said, we think it might be possible that we could take a Moneyball approach. And of course, Moneyball is this book and movie that's come out about looking at baseball teams not as individual players, but instead looking at it as a team and understanding how to put the right team together, rather than focusing on how to get the very best pitcher and the very best batter and everything else, and everyone had to be stellar, rather to start leveraging the team's individual strengths and focus on it as a team. And so, you know, the movie Moneyball had just come out, and you know, this kind of concept people were talking about in healthcare, and we brought this little demo to Don, and he said, well, if you change it like this, and if I could do this, and if I could pull it like that, and if I could do this other thing, then yeah, I can do this. And since that time, what has happened and what we rolled into is that we have taken an approach that to managing doctors and arranging doctors and having doctors team together that's molecular rather than atomic. And what I mean by that is when you define a molecule, the definition of a molecule is the smallest unit of a substance wherein which if you divide it farther, you lose the essential features of that substance. So H2O is the perfect example, right? If you split H2O into hydrogen and oxygen, it's no longer a liquid, it's two gases. The essential features of water are lost, right? So 2 atoms of hydrogen and 1 of oxygen is the smallest unit that you can consider and still have the same features, the features you're looking for. And insurance companies and health reformers and everyone have been obsessed with looking at doctors and hospitals, and that is the atoms of the healthcare system. But we're focused on the molecule, which is to say, given a single patient, what is the team of physicians and hospitals and labs and radiologists and therapists and social workers, what is the minimum team that can service all of that patient's needs? And when you start looking at things at a molecular level, right, when you have this team and it's the smallest unit you can have that still serves all the things the patients need, which is to say, if you took away one element, if you took away the hospital, if you took away the labs, if you took away the cardiologist, say, it would no longer be able to do everything that a patient needed, right? If you stop and don't go any deeper and don't split it apart any farther, you see some really interesting features. So, for instance, you might attempt to analyze at an atomic level, say this physician prescribes too much narcotics, or this primary care physician prescribes too much narcotics. Well, when I look at and analyze my own physician, he has a pain specialist that lives right down the hall from him, and that pain specialist prescribes, and this is all, I know this, right? This is data that we have, this is open data, and I know that his pain specialist prescribes Vicodin and oxycodone and all these very, very serious narcotics. And I also know that my primary care physician doesn't. But what if my primary care physician didn't have that pain specialist? What if he was out in some rural area in the middle of nowhere and that pain specialist didn't exist? Well, then he's prescribing lots of narcotics. He's not going to let his patients be in pain, right? There are some pain cases where pain is just too bad. You have to use narcotics. Narcotics are a very dangerous class of medication, but there are some things that only narcotics address. So if you attempt to analyze whether or not my doctor is doing a good job, you have to account for the fact that he has a pain specialist. If you attempt to evaluate that rural doctor who does not have a pain specialist within, say, 500 miles, you have to account for the fact that he doesn't have it, right? So, when I say molecules, not every molecule in the healthcare system is identical, but that is the right level to look at things. So as we compare these teams, right, we're trying to unpack and use big data techniques to unpack what makes an effective team and to stop obsessing about individual physicians, right? It does not really matter if my physician was prescribing narcotics or not. There's a way for the primary care to do that well, and there's a way for the specialist to do that well. If a primary care in a rural area doesn't have a cardiologist, he's going to be doing more Lipitor, et cetera, et cetera, et cetera. And all the procedures will change, the diagnosis will change. So good medicine, there's not a single formula for it. In the same way, there's not a single formula for a good baseball team. But in general, what we are interested in doing is we want to stop the atomic level analysis. We want to move up to the molecular level, and we've been successful at doing that, wildly successful. And Don was the first person to get it. In fact, in some senses, he got it before we did. So when he and the other people from PPC saw what we were doing, they really informed our approach. And so a lot of the intelligence that we have built over the last 6 months to a year have been based on kind of this fundamental shift. And I think this notion that you interview and find out what the patients really need, that's, unfortunately, to push the analogy as far as it'll go, if I'm playing Moneyball with doctors, the patients are the baseballs, right? And so the baseball's perspective on a baseball game is very different than everybody else's, right? And I think that's a great example because some parts of the healthcare system are just as traumatic as a bat. And they don't necessarily want to have those experiences any more than a baseball does. So as patients move throughout these teams and they're moving throughout these systems and they're moving around, having that as the fundamental insight that's driving our kind of data intelligence stuff, it's allowed us to actually start asking the question, what should the healthcare system look like? And because of open data and the open data philosophy and approach and open source approach that PPC takes, and this kind of patient-focused angle, those two things together are allowing for, I'd say, a renaissance of data analysis. 5 years ago, even, the only people who had the view on the healthcare system that I do now and that Don does now as a result of this open data were people like the VA or Kaiser or the federal government with Medicare and Aetna and these companies that were able to see in their own data what was going on. And when they looked at their data, they looked at it with a bias. So Aetna says, I'm going to look at this data, I'm going to figure out how to make more money than I do right now. And that's the same thing that Kaiser does. And the VA, they look at it with a bias too, which is to say, I'm going to look at it for how do you make things better for veterans, which is not the same thing as everybody. So now that that data has become open and that data has become liquid and that data has become either cheap or free, we can start doing an analysis, which is to say, how do we make the healthcare system actually work for patients? Which sounds silly, but that's never been done before. The basic question that I asked 10 years ago, when I first got involved with open source software was, what could we change if we would stop hoarding? And what could we change if we shared source code, data? I mean, there's projects that I've been working on for this open data stuff that have been 5-year projects. And technically, I was one of the people who submitted FOIA requests for this procedure data that's recently come out and caused a lot of drama. And I've submitted to the federal government, and I've submitted FOIA requests. I submitted one that nobody was expecting, the referral data set. That has been met on the administrator's side, which, the Obama administration, at least with regards to healthcare, but at least in HHS, Obama's commitment to open data and to openness in general and transparency has been exemplary. So my FOIA requests were met with sympathetic ears on the inside of the administration, and in partnership with them, they have released a tremendous amount of data about physicians. So there has been a whole shift in the way healthcare is organized to creating a situation where you can at least perform analysis and anybody can play Moneyball with doctors. Thankfully, because of Don, and because we've been thinking about it for a long time, we're awfully good at it. So I hope we're going to be really in a position where we've kind of gotten one of the top 10 teams. We're vying for the champion, so to speak. We're building a healthcare system that rivals some of the work that Kaiser has done, and Geisinger and Intermountain Health, and some of the other really deeply integrated systems who are able to leverage data in the same way we are, but it's accidentally. They grew an enormous business and then they were able to leverage data. We're using data to grow an enormous business. It's really interesting. I mean, we talk about these terms like patient-centered and things like this, and those terms frustrate me, I'll be honest with you, because there's a lot of lip service. There's a whole lot of lip service. So one of the things that we do is we do social media analysis of what patients actually say about their healthcare organizations. And one of the most frequent complaints that patients have about healthcare organizations is parking, almost universally, right? So if you ask any hospital in the United States, are you patient-centered, they almost all will say yes, absolutely. But then if you ask, do patients have better parking than your doctors? Almost universally, the answer is no. So whenever someone says they're patient-centered, and I ask them about their parking, right, which is the thing that patients obviously actually care most about, or one of the things at least they're willing to comment on social media about, almost invariably, it's like, well, we're patient-centered except when it comes to significant issues like parking. So, one of the things that we're excited about is that as the PPC forms, we're really shifting towards the virtualization of medicine. And telemedicine is like the first step on that ladder, but as you shift to the virtualization of medicine, there is no parking in cyberspace, right? In cyberspace and using the kind of digital systems that we're kind of enabling, and not just enabling, but open sourcing at PPC, you don't have the parking problem. And I don't want to overemphasize that point, except to say that that's almost an analogy for everything else we're doing, right? Is that when you have a digital space, you can there's no waiting, right? So you can have an appointment at a particular time from your kitchen. You're limiting all of the friction for the patient, and you're making the patient and a doctor into a partnership. And so I really like it that, people say patient-centered, but I love the fact that in the patient-physician cooperative, the patient comes first. And I think that's, again, one of these small, subtle things, but I think that means a lot.